Now I do want to talk a little bit about the technique of C-section. Not a lot, we're not going to go into great detail, but at least some of the things to consider when the delivery is being performed. I'll take the approach of maybe you're a student watching your first C-section and you want to make sure you understand the levels that we're dissecting through to get to the baby. So the first lesson here is anatomy. I'm not going to go into the details, but for the medical students, make sure that you do review the anatomy of the pelvis prior to seeing your first C-section if you can. Pay particular attention to the blood flow to the uterus, the various vessels that you're likely to see, the layers of the abdominal wall. And then other pelvic organs, things like the bladder and the rectum, the sigmoid colon, all of which are going to be potentially visible during the C-section, and their relationship to the uterus and their location does influence the technique that we use and some of the things that we do. Can't stress enough, prior to watching your first C-section, really study the anatomy so that you'll have a good idea of what you're looking at. One of the first steps in performing the delivery is the skin incision. Usually this is a transverse incision of the Fannin steel type. There are some variants of this. There's the Joel Cohen, there's a Pelosi C-section, but what they all have in common is that it's a transverse incision done low on the abdomen, which is thought to be more cosmetically acceptable to the patient, but also to be less painful than a midline incision and to heal better than a midline incision. So we make the skin incision, and then the subcutaneous fat is divided, and then the next thing is to expose the fascia. This is also a transverse incision usually. Making a transverse incision in the fascia does allow generally for adequate exposure of the uterus and to perform the delivery pretty easily, although in some cases we will have to consider making a midline skin incision vertically as well as a midline fascial incision, depending on what else might be influencing our decision for C-section. If we're considering a hysterectomy for a cancer or for a placenta accreta, we might consider that we could do a vertical incision for that. But by and large, the transverse fascial incision is going to be the next thing. The next thing is the peritoneum and the rectus muscles. We don't cut the rectus muscles in most cases, which is one of the reasons that the C-section allows the patient to get up and walking pretty quickly afterwards, is because we don't have to actually transect those muscles. We usually spread the rectus muscles, which exposes the peritoneum, and then people enter the peritoneum in the midline. It's often done sharply, but in some cases you may see a blunt dissection of the peritoneum. After the peritoneum is open, that exposes the uterus. And what you see is the anterior surface of the uterus. And then we have another choice to make, and this is whether to do a bladder flap. And what the bladder flap is an incision in the fold of peritoneum between the bladder here and the uterus here. And by making this incision, it allows us to pull the bladder down more caudally, which gets it off of the lower uterine segment and allows us to make a lower uterine incision. The other thing it does, if you think anatomically, as the ureters come into the bladder, they come from lateral to medial, so that as the bladder moves down, that moves the ureters more laterally away from the surface of the uterus and makes it less likely to injure them. So it accomplishes two things. This is an optional step, however, and not needed in every case, but it's at least something to consider as you go in. The uterine incision is the next important thing. And over 90% of these are going to be low transverse incisions, meaning that we cut into the lower uterine segment only in a transverse fashion. And this is really important because this is the type of C-section that is safest when considering a vaginal birth after cesarean. That's a talk for another day, but the low transverse incision is really the safest there. Recommendations are that a patient who's had 1 or 2 lower uterine segment incisions can be considered for a trial of labor after cesarean, and low transverse is going to be usually the safest for this. You'll often see in the op notes, particularly that the residents write, they'll say that a patient had a primary LTCS, low transverse cesarean section. And the important thing to remember is that low transverse in this case refers only to the uterine incision. It has nothing to do with the skin incision. A patient can have a vertical skin incision and still have a low transverse uterine incision. And so when you're counseling a patient about trial of labor, this is the thing that you really want to know about, is what kind of uterine incision did they have. Can't tell anything from the scar on their skin. So it's really important that you, if you're going to counsel them appropriately, to look at the operative report if you have it available to you. So we make the uterine incision. It's usually done sharply in the midline, and then you may see the incision expanded transversely using either bandage scissors, or the surgeons will use their fingers to stretch the hysterotomy, either transversely or in a cranial caudal fashion. There's pluses and minuses to doing them either way, but the goal is to make the hysterotomy large enough that we can extract the baby through. So then we deliver the baby and subsequently the placenta. The delivery is usually accomplished by one surgeon placing the hand inside the uterus underneath the fetal head, or if it's a breech-presenting baby, under the breech, or by grabbing the legs or feet and bringing them through the incision. And then the assistant will usually apply pressure to the fundus to help to push the baby out. Once we've delivered the baby, we then remove the placenta. This is most often accomplished by massaging the fundus, and then we begin the closure. The closure is usually done in several layers. The uterus is most often closed in 2 layers, although sometimes 1 layer is sufficient if the patient isn't planning further pregnancy. But we do want to make sure we have a good hemostatic closure of the uterus before we move on to anything else. Then you can consider doing any additional procedures. Most often, the tubal ligation is the one that I'm referring to. If the woman's chosen to have permanent sterilization, this would be the right time to do the tubal ligation. Appendectomy at the time of C-section has not proven to be a very beneficial procedure, so unless someone actually had a appendicitis at the time, we usually don't do that. Things like ovarian cystectomies can be performed at this time as well if you need to. After that's done, the uterus is inspected to make sure that it's hemostatic. You may or may not have actually drawn the uterus up out of the abdomen to do the closure. Some people do it in sight. Some people do it by exposing the uterus onto the abdomen. Either way, you make sure that it's not bleeding anymore. You might or might not irrigate the abdomen and pelvis, and then you close the fascia. Most often we use a delayed absorbable suture, something like PDS or a polygalactin, like Vicryl type suture. Although occasionally you will see people use permanent sutures, particularly if someone's had a problem with fascial dehiscence or hernias before. The subcutaneous tissue is often reapproximated, particularly if the depth of the subcutaneous fat exceeds 2 centimeters. And then the skin is closed. The skin can be closed with sutures or staples, which is largely up to surgeon preference. There's not compelling evidence to do it one way or the other. And after closure, the procedure is finished. The post-op considerations for C-section, in order to minimize the morbidity, are things like early ambulation, get the mom up and moving to help prevent thromboembolism. We want to get the Foley out, if she had a Foley placed for the procedure, as rapidly as possible to help prevent catheter-associated UTIs. You may leave it in longer if there was an injury to the bladder. Most of the time after the C-section, we let them begin oral intake sooner rather than later, often in the recovery room. And then the other important thing to keep in mind is getting mom to the baby as quickly as possible. There's no reason that a C-section has to result in a long delay of getting the mom and baby together here at Greenville Health System, because we want to adhere to the principles of baby-friendly maternity here. We do try to get the baby skin to skin with mom as quickly as possible. Sometimes in the OR this can be accomplished, and if it's not done in the OR, in the recovery as soon as we can. And we want to really get that baby up there to mom to start initiating breastfeeding. We want them to have that initial hour of bonding time. Get that done as quickly as we can. Well, this has been just a quick overview of cesarean delivery. Maybe in a future broadcast we can address a little bit more about trial of labor after cesarean and some of the issues involved in that. Thanks for your time.